Yes. Okay, we are live. Good
Good
morning, good
morning.
afternoon, good evening, everyone. So lovely to see you again.
You as
Hi,
well.
Kimberly. How are you,
Hi.
love?
Hi. Good morning. Good afternoon to everybody. I always love that show, that movie by Robin Williams, and he always say, "Good morning, Vietnam."
Oh yeah, I love this movie. I
I
love it.
love that movie, and I
It's
know it's not
amazing.
Vietnam here, but it's like I always wanted to say that, so now I just said that. There,
That's true. It's actually, yeah.
such a good movie. Such a good movie. How are
Yeah,
you
yes.
doing? How's everything there? Besides
It's
cold.
gray. It's cold. It's gray. Actually, kind of white, more than
Oh,
gray. A little bit concerned. But yeah, this is UK. But I love this. I love UK for this reason as well, because one of the things that pushed me go away from Italy was that for me it was too hot. I mean, it's good where you are, in summer and you are near the sea and the beach, and it's lovely, but it's too hot to work and do everything. So actually, I love this weather.
oh.
I think Florida is amazing. It's just
Yeah, it's
lovely.
raining. Yeah, it is. It has definitely been beautiful here. It's raining today. We much needed the rain though, so I'm not going to complain. I did want a
Okay.
beach day today, or some sort of something of getting out of the house, since I feel a little better today. But anyway, anyway,
That's
so we've
okay.
been yeah, so we've been talking, so much about leadership, and we've been talking about people feeling invisible, and we've been talking about what does it mean to be in this profession and feel seen? What does it mean to feel like you're recognized? And I'm not talking about like a pat on the back or anything, but just sometimes just that simple thank you, that simple appreciation that I see you. How many times do we not see that anymore? And I just, in this conversation today, I'm hoping that we can kind of break through all those barriers. What causes those barriers in the first place? Why are we not
Mm.
talking to one another? Why are we not sharing our stories? Like my post today, I was talking about just being curious. How about just be curious? You're working side by side with these people every day. How much do you really know about them? Have you ever
That's
thought to
true.
ask? Have you ever thought to ask? And instead of being so quick to judge somebody, or thinking, oh, they're a huge failure, or they should have known that. How about being curious and saying, hey, tell me a little bit about you. I'd just like to know a little bit more about you. And I think if we have a little bit better relationship with people and an understanding. Good morning, Brittany. If we have a little bit
Hi.
more, how are you, babe? If we
Oh,
have
so
that,
sorry.
you're okay. You're okay.
You
If we
okay?
have
You're fine?
You're fine, honey. If we have that understanding of just being curious and just reaching out to people, and because you're spending so much time with these people every single day, why aren't we being curious to say, hey, just tell me something about you? Tell me something I don't know. I would love to hear more about you. Tell me about your kids. Tell me about your why, what brought you here. Tell me about your journey. Just something. I think that we need to focus so much more on relationship building and team building and just
Absolutely.
support of one another, because we don't have that anymore. And I still can't wrap my head around why that is.
And in fact, sorry, continue.
No,
Sorry.
no, no. I'm good. You go on.
Uh, in fact, one of the things I actually work on, team dynamic, I work on when I do my work with nurses retention. So, and also, I don't know, I feel this in UK, but I believe in other country as well. Just because I come from another country with a different culture, we used to get along as not really friends, but well, so many friendship actually happen in the workplace in Italy. There's a lot of toxicity, bullying as well. Don't get me wrong, but at least I come from a culture that love to build friendship. When I moved in UK, I found that people like try to stay distant. They do really want to make really deep connection, like friendships like that. I mean, you don't have to become friends with your coworker, but could happen. Why not? Don't put barrier. Brittany, it's so lovely to see you. We just started because it was the time, and so we start this conversation. But we so love to have you here. So many people already show up. How are
Oh,
you?
thank you. Thank you for having me. I apologize. I was having some like technical delays. It's like all the, all the allow, Mike. I'm like, yes, just do it all.
It
All of
wouldn't
it.
be a podcast if there wasn't a technical glitch. Let me tell you, I may come
Okay.
in and out, so that's not normal. That's usual for me.
Okay, great.
Thank
Well, thank you
you,
so
thank
much for
you.
having me and inviting me. This is exactly the right conversations I want to be a part of. So thank you.
Yeah.
And Kimberly know you better, but I also interact with one of a few of your posts, so I read you as well. But lately, I've been a little bit far from LinkedIn because of certain university commitment. So Kimberly said we have to really have her because she's very
Oh,
vocal about what we're actually doing. So we got straightforward, and we're so glad you are here. You are
yeah.
here.
Thank
Yeah.
you. And thank you, Kimberly. I appreciate that.
Oh my goodness,
Shout
yes,
out.
yes. All these conversations that we've been having, in the comments and the posts and everything, it's like, oh my God, I love this girl. We've got to have her. We got to have this conversation. We got to have this conversation off LinkedIn. Still on LinkedIn, but you know what I mean, with live and in person, and really kind of get down to the nitty gritty of it,
I
and
agree.
why we're seeing what we're seeing, and how do we come up with solutions together? Because I think that's what
Yes,
needs to happen. We all just need to keep
absolutely.
talking about it. We also need to put these words into action, and we need to
Yes.
support one another, because I think the
Hmm.
support for one another has, for whatever reason, left the building. We need to bring it back into the
Left.
building. So, Brittany, would you please take a moment, and Dina and I will mute our mics. And when one person is not talking, we'll go ahead and mute. It just saves the background noise.
Sure.
But please take a few minutes and introduce yourself to us. Tell us why you decided to join us today and what your thoughts are. I'd love to hear them.
Sure. So my name is Brittany. I have been a nurse for a long time, for about 15 years. My experience ranges from acute inpatient. I did that for about, I think it was 13 years. I just left the bedside a little over a year ago, just to kind of expand my reach. But during that time, I did everything from adult ICU. I did majority NICU, so itty bitty babies, all the way up to adults. So after I left the ICU, I kind of stayed on as a per diem role just to kind of keep my skills up. So I would often transition. I would have one shift where I would go to all these births and take care of NICU babies, and then the very next day I would go work in the ICU and see go be a part of a code and be on the other side of life. So it was a really unique kind of place to be. And then towards the last part of those few years, I did home health nursing. And that's really where I started to see a lot of the gaps, I think, is in healthcare, is seeing that. So what I did was transition neonatal babies home, once they were done their journey to NICU, transition them home. And that's when I started to kind of really see, I'm like, wait a minute, why isn't this adding up? Wait a minute, why couldn't you make this appointment? And I started noticing all these other, like just all around barriers to the baby, for families. So I kind of focused a lot of my attention there with like maternal mental health. It's still really close to me. So after all that, I was like, I need to take a step back. I need to take a step back from the bedside so that I can, I was working on my grad degree, and I also take care of my grandmother. She's been living with me for 10 years. So her health was declining. So she needed a little bit more of my attention. So being on the other side of the bedside also gave me another perspective of, the system as a whole. So I ventured out and I went into case management. I worked for Department of Social Services in Baltimore City for foster children through the MATCH program, which is a really big eye opener as well to those gaps. I worked there about 6 months, and I'm with Sage Health as a nurse case manager. But it's a really unique role because I work for the whole Baltimore market. We have 3 clinics doing geriatrics, but I get to go out to hospitals to see our patients. meet them in the community, meet them kind of wherever they're at. And it's really been in this experience that I've really started to kind of like put the patterns together and the pieces together. And then kind of started getting more involved with LinkedIn and, realized I'm not alone in my thinking and these really exist. It's not all just in my mind. I'm not just, like they're legit. And I remember when I left the bedside, I was really kind of lost. I felt lost almost. I've been, as a nurse, you come out thinking, I'm just, you go to the bedside. And so when I left, I was just like, oh, what am I going to do? And I remember when I first came onto LinkedIn, I think it was Ann Richardson, I think it was, and she was speaking to this. And I remember she messaged me personally and she was just like, you're not alone. And that right there gave me just what I needed to move forward and just continue with this systems thinking, kind of bridging things together. And that's what's led me here.
Thank you very much. And we have, what's in English? Well, we do something every time we go live. We do have a disclaimer before start. So thank you very much for your introduction. Just before do that, so what do you think you want to talk about that you really want to bring to the table today?
I think it's kind of what we've been talking about, which is, we've been talking about what the issue is as a nurse at the bedside. We talk about it with our coworkers. We talk about it on LinkedIn. We talk about it in all these different spaces. But what, there are actionable things that can be done to, to help and to prevent where we're going. So I think that's what I want to kind of speak to. And it's more of like design related, structure related ideas. That's kind of where I'm thinking. What about you guys?
Yeah, I think the same thing. I think we have this huge breakdown in communication. There's always this huge, no matter what industry you're in, no matter what role you're in, there's always a breakdown in communication.
Mm-hmm.
And I think that's probably a good start. That's a good start for what somehow someone perceived something and how something really was. But it's those tough conversations that we're not having. It's those conversations that need to come to the table to where everybody's on the same page. It's not, you're not left with thinking, well, that was really messed up. Or, then you have this perception of it being something that it wasn't. So it's having those tough conversations that we're not having anymore. So yes. I feel that would be also a good point to dive into today is where and why do we have this continuous communication breakdown? And why are we continuing to not support one another rather than work together, work collectively and support each other? Because that's where it has to start. We have to start treating each other like human beings. Go back to what was the old saying, if you don't have something nice to say, then don't say nothing at all.
Don't say it at all. Yeah.
Don't say anything at all. So, right. So Dina, do you want to go ahead and do the disclaimer? Bring that bad girl out.
Yeah, absolutely. I'll do it just right now. I just want to say that we have already a couple of very interesting comments that were following our initial conversation. They are part of this conversation as well. Let me go to the disclaimer, and then we're going to read these two comments. I think we can start from there straight away. So let me move over there. And so here we go, our disclaimer. Enjoy.
Disclaimer, the Hierarchy Betrayal podcast. Warning, unfiltered, unscripted, unapologetic. This podcast is brought to you by two nurses who've had enough of the BS. We're talking about the real healthcare system, the one that exploits nurses, commodifies patients, and protects profit over people. What to expect? Zero scripts, just raw, honest conversation. F-bombs, probably more than a few. We're passionate, not polished. Uncomfortable truths. If you're a manager who's complicit in the hierarchy betrayal, this content may cause discomfort, embarrassment, or a sudden urge to defend the indefensible. Not suitable for sensitive managers allergic to accountability. Anyone invested in maintaining the status quo. those who prefer their healthcare conversations sanitized and corporate approved, suitable for nurses tired of being used and abused, healthcare workers ready to call out the mafia, anyone who believes patients deserve better than a system designed for profit. If you're here, you're ready for the truth. Welcome to the Hierarchy Betrayal.
And there we go. Brittany has some problem with connection, but she will join us.
That's okay. That's okay. We always do. We always have a little glitch.
As usual, of course. It's the beauty of live events, isn't it?
Yeah.
Should we start reading the
let's
comment?
read what Cleopatra said. And I love her name. That's a beautiful name. And Cutie and I actually connected this morning on LinkedIn and had a brief conversation. So she says, great conversation. Being curious with colleagues is good mechanism for engagement. Absolutely. Absolutely. You have to be curious. You have to want to know something about each other. You have to, like you said, you don't always have to be there to be your friend. It's not, but it does make the day go so much better. It does make everything so much better when you're on the same page, you're working cohesively together, you support one another. I've got your back, you've got my back. I'm struggling, you see that, you help. It's so easy, but yet you guys, how come we're not seeing more of it? Why are we not seeing more of that collaboration and that support? That's something that just makes me insane. It's so easy. Being kind is so easy. Having those conversations is so easy. It's just so much as simple as, are you okay? What can I do for you today? Hey, I got a minute. Do you need a break? Here, go take a break. I got you. We just don't do that anymore. And I don't understand why. So Cleopatra says, let me put my glasses on.
It's very following this comment.
So Cleopatra says, in regards to building friendships in the UK, and Dina, you can relate to this, has changed over the years due to the culture. Coworkers use the person information about you and spread it throughout the ward unit, and then it's used for bullying. Senior management is aware of this horrible culture, and they contribute to it. And that's so sad when we talk about being curious and sharing insights and things about you that maybe other people don't know. I guess you just have to be very decisive in what you share and very choosy in what you share. And trust is so hard. It's so hard to trust people. And I'm not even sure why that is anymore. But I don't know about you guys, but I think sometimes they have ulterior motives. Why is there an ulterior motive? We talk about the hierarchy betrayal and this stepping on one another to get higher. It's not about bending down and bringing people with you. It's about stepping on people to climb that ladder.
Yes.
That needs to stop. That bullying needs to stop. That nurse-on-nurse violence needs to stop. Because we are all here for the same reason, to take care of patients, to take care of each other. But for whatever reason, we're not doing that. So, Brittany, I would love your thoughts. What do you think about what Cleopatra said?
I think I hate to say, but I mean, I've witnessed it and I've seen it myself. And I think that it goes back to what you said about trust. Trust and not letting it back to the nurse manager level, because when the nurse manager is involved, it just kind of facilitates and it just makes the whole situation worse. And then I can't help but think, because I recall, like, when I first started with nursing, there was that teamwork aspect. We could I'm still friends with some of them today, but when I last left the bedside, it seemed exactly kind of what we're speaking to now, where like Kimberly said, it's like you have to step on one another to get ahead. And there's also these little maybe pockets of people who are assigned certain tasks, maybe by the manager or whatever reason. Maybe they just take ownership, maybe because they want to, but then for some reason they almost gatekeep the information. It's like, I'm going to hold this and I'm not going to share it with anyone because I want to get noticed, or whatever the underlying reason may be. So that it usually is a smaller group of individuals, but it creates this huge environment that is not sustainable for anybody else. Everyone else kind of feels left out, and if anyone else brings ideas forward, they're almost kind of shut down by this other little pocket of people who may or may not be little closer or appear closer, to management, to leadership. Also talking about like clinical ladders and things like that, which I think are great in nursing in theory. I think it's wonderful for advancement purposes, but sometimes even that can come across as, well, I'm a clinical nurse 2 or 3, so, or I'm a permanent, it creates a lot of like these hierarchical things. And some people, they seem to take it as I hate to say better, but I can't come up with the right word for it right now, but in a nutshell, it just creates this culture where people then feel they can't speak to one another, at all. They're afraid to share literally anything. When really good, solid teams, you need that trust, and it's up to anticipate, what you may need in a code. I remember having a coworker where I would just, she just would know what I would need, and it would just, I put my hand out and get ready to ask for it, and it was right there, because we would have conversations and we just knew each other really well. And I think we've lost a lot of that through all these different kind of mechanisms that exist currently. And I feel like people are afraid to speak up about it, because if they have, nothing is done about it, or they're retaliated against, or something negative happens. And so they just stick their head in the sand, just keep working and kind of distance themselves. And I think that creates that kind of culture.
And
I agree.
if I may, so studying leadership was, because you say something, you said that managers kind of incentivize this toxicity. But actually, what I think, what studying leadership, but what I realized is actually the problem in nursing is that we have a problem in leadership, because more than incentivize or push through, it's like actually that is the manager or leader fault. Because when a manager leader create a certain environment of toxicity, people are not feel psychological safe. So this is why they start to be toxic one another, because they want to defend themselves better in a way that if it's their fault, it's not my fault. So it's just kind of protect themselves by bullying others. And I witnessed this over and over again. And Kimberly worked in several countries, in several states of the United States. I work in 2 different countries, and so I saw this in 2 different cultures, and I realized that the key factor of a toxic team is the leader, the team manager.
Yes.
I witnessed amazing teams in Italy and in UK, and I witnessed terrible team in Italy and UK, because they was not really able to create that psychological safety that allow people to be trustworthy as well. Because if you understand that we are a team and we help each other and we are all women and we can all make mistakes, but we support each other, protect in a way that I help you not to fail, or I help you to learn from your mistake, this toxicity actually is reduced, even if the system around could be toxic, by the way.
It could be, and it should be. It should be addressed. It should be addressed immediately. And this is where I also think using anonymity, like surveys for people, is good to get a very like a pulse check on your culture, because a lot of people aren't going to come forward with their name attached to it. So that is something I have experienced, and we received pretty accurate results, I think. And it was shocking, I think, to some people to read it, maybe even, a little hurtful maybe, but either way, it was the truth. So let's take the truth and let's act upon it. Let's do something about it.
I agree. And I think too, you talk about being with that coworker that just, you put your hand out and they know, you know, you give them that look and they just know. We used to have that. We used to have that. I got you, you got me. I didn't have to say a word. I could just look at you and you knew exactly what I needed or where this was headed. I used to have a doctor when I worked in labor and delivery, and I was there over 20 years. And we'd be watching a strip, we'd be watching a patient, and I would just look at him. He'd look at me. I would nod, like,
You would
go get your room ready. Go get the room ready. So
exactly.
I opened up the OR and I scrubbed and first assisted with all the C-sections. It was always, we just had that cohesiveness. We just had that understanding and that trust. And it is really difficult to build trust, especially with physicians, because their name is on so much more, and they are so much more liable than we are. But again, it's building those relationships and that trust with people.
Yes.
That you always know that I have your back. I have your back. I'm not going to let you fall. I'm not going to let you fail. I'm not going to let anything happen to you. I've got you. I just don't understand where that went. And these things we talk about, and especially because healthcare is primarily women. So we have these cliques, you guys have all seen them. We have these cliques, and you either are in the clique and you fit in, or you're kind of in a mess, right?
Yes.
So I find when people are deciding whether or not they speak up, they're scanning the room. They're like, oh, who's in the room today? Do I speak up? Do I shut up about this? I just keep my head down. Just keep my head down, do my job, and go about my day. But it's when we keep shutting those people down, where people don't feel like they have a voice, you've just created such a toxic environment. You've created an environment where it's not safe. They don't feel safe for themselves. How does that trickle down? Because we know absolutely that it trickles down to the patients and the care that we're providing for the patients. There's always a ripple effect. That's always there.
Always.
So when we're having these conversations, I think it's, again, getting to know your people, because the people are the business. The people are the foundation. And it only takes 5 minutes of walking around your unit to feel it. You either feel a good vibe, you feel oh God, the manager's coming. Look busy, pretend you're doing something. You know what I mean? Because you're like, oh my God, how is she going to perceive me? Or how does she look at me? Or, those things. And it's just the continuation of working together and these environments. We are not, if we are not changing it, you guys, we're choosing it. It's that simple. If you're not changing what you're saying, if you're not making a difference, if you are not willing to step up for someone or step up for yourself, even because of fear. And we know that this profession is so fear driven, the golden handcuffs, and we're a fear of losing our job, fear of being labeled, fear of being retaliated against. I mean, I could go on. I don't have enough fingers. We could just go on and on and on about those things. But what if we had enough fingers for all the good things? Because this is such a beautiful profession. It really is. And we are all capable of doing better. We can all do better. Nobody is perfect.
Right.
And it's admitting that, and raising your hand. If you don't know something, raise your hand. And there shouldn't be that fear of raising your hand and talking to one another.
And asking questions.
I'm so glad that you came on today, because, oh my goodness, this conversation has been building all week through these posts and these comments. Let's see. So
I think that's too. Oh, there's a comment. I'm sorry.
Yeah, there's a comment. She says, so Nafi, I hope I said that right. Nafi says nurses eat their young. Oh my God. How many times have we said that? We've said that. I mean, I've been in healthcare 36 years, and I've heard my entire career. That's ridiculous. It's ridiculous. We need to stop that.
Yeah, I don't know if it's still
Anyway,
happening in
go on,
nursing
Brittany, what
school,
were you
but
gonna say?
I feel like it kind of happens there, kind of starts there, at least for some programs, and I think it's more of a, they're trying to prepare you for what nursing is, but I think that there's also a line, still a line of respect for students and teachers, but again, to your point about the unit culture and trust and how people speak up, and if they speak up, there's so much data to be derived from that, and so much data that could be so useful to healthcare. so useful to patient outcomes, so useful to leadership as a whole, if they would listen, and if we can get through that bottleneck, right? So even for the nurse managers who are engaged and they're trying and they're, but they're being pulled to meetings, they're being pulled, further and further away from their teams. I think that's also creating a disconnect. I don't know if it's, these large like systems that are creating these where you have to be present in all these meetings, and it's pulling them away, it's detaching them from the culture of their team. So when they come back and they're like, oh, wait a minute, this isn't what I expected. And all of a sudden, I think there was a post, but I don't know what it was, but all of a sudden she came back and her nurse, and actually you posted, Kimberly, about your director friend, and her nurse was gone, and she was just, again. So I think that if we can just get that information, really through, and it can be done. There are many ways that we could do it, but I think it boils down to, do they want to do it? Do they really want to extract that information, which is gold, truly gold? That's what I think.
I think that the system play a huge role in this, but what I think is that, because this is a common trend I can read from others as well, that the system or systems have been built against nurses. And I actually believe not really. What I think is the system have been built follow the profit probably, and also following the most power that at least it's been for century, the most power professional care, which is the medical profession, the physician. So I don't think that the system has been built intentionally against us. I think that's been built to protect that profession, that institution, and also at some point that became profitable. The system became profitable. So I think that it just happened. It's just the way it happened, that the system has been built in that way. It doesn't really facilitate nursing for sure, but I don't think that really has been built necessarily against nursing. And I don't really like this veil of victimism that I can read over and over and over again from nurses on LinkedIn or Facebook, but also on YouTube. And I don't like it, especially because if you feel victim, it's like you give your future in the hand of others. You say, I'm the victim. I have any responsibility in this. It's their fault, it's not mine. So I just need to protect myself, or even better, let me go away. So that's fine. I will be better. The problem is, and this is a career coach, I can say, burnout, you can't cure burnout, just simply leave the nursing profession. You can leave the hospital, you can leave the profession, but you need to work on your burnout to heal your burnout. Because any other profession, I mean, so many professions are burnout. The funny thing is nurses want to move to, the creator in industry, which is one of the most burnouts after nursing. So I think that we should recenter our focus on us, because we really need to work on ourselves and understand how to rebuild relationship again, so then we can build power. Because another thing I think that I'm a believer is, I see doctors, they protect each other. They may like each other, but they protect themselves because they protect the profession. They believe in their profession, which is
exactly.
And that's
yes,
but we don't
do. A good point. It's such a good point. They do, and if they don't agree with each other, they do it behind closed doors and amongst each other. But they protect the profession. That is I'm so glad you brought that up, because that is a big differentiator between, physicians and nurses. I mean, there's many other, differences, but to your point, again, we need to get together, because together we are we are, healthcare. There is no healthcare without nurses. So if we were just to come together, and be united and on the same front with all these different things, I think we could really make a change.
Kimberly, I love so much because you talk always about, relationship and watch each other. You just say that. Can you go further? Just continue this conversation about, we know are united, right? And how this conversation can help to become united again. Because the association, I feel like they're just thinking about glamour and they are very disconnected from us, right?
Yeah.
So, Kimberly.
In talking about how the physicians protect one another and they protect their profession, it sounds so easy, right? Doesn't that just sound easy? Mm-hmm. And if you don't agree with somebody about something, you do it behind closed doors, and it's handled, it's done, you move on. For whatever reason, it just kind of floats. It just stays. You're breathing it every single day. It doesn't go away. That toxic air, it just kind of follows you around. It doesn't change, and you were talking about the surveys, Brittany. And I think they are good for a lot of reasons, but why do we never see them? Why do we never see what other people are saying? And I've been brutally honest, and I don't mean brutally in a bad way. You asked me, I don't know, I think there was 10, 15 questions maybe about the organization and how I felt things were going good and how I felt things were going bad, where there was a disconnect, where I think there was a breakdown, how we can do this better. And answering those questions as honestly as I could, because I wanted to see it improve. You're asking me these questions for a reason. So I'm going to give you my honest opinion, not to blame anybody, not to break anything further down, but to show you from my lens, because you asked me. If you're going to have these surveys, why are you asking people these questions and getting the responses? But if it's not something that's comfortable, or if it's not something that you want to hear, we never see it again. And we never see what other people said in these surveys. We never get, I think that should be something, why not put it out there? Why not put it out there to where all these surveys were sent out, and have a Word doc, or have some sort of a something that these are what the people in this culture are saying. This is what people are saying. Because how many times would you be like, oh my God, me too. I had that same experience. Oh my God, somebody said it out loud. You've opened up conversation. You've opened up the opportunity to make the changes that we need to see. But if you're not sharing all of that knowledge, if you are not sharing those insights and those perspectives from the people within your culture, all you're doing is squashing it. You're pretending that it doesn't exist. And that's probably one of the biggest problems, is you're pretending that it's not happening, that you have this great culture, and it's shown on the websites. And when you apply to jobs, we have this mission and we have this vision and we have these values. But do you? Do you really? And how comfortable are you in talking about it? And how comfortable are you in saying, oh, you know what? We really got that wrong. Here we thought we were doing really good. Shit, we ain't doing anything like we said we thought we were. And I think it's taking that ownership and being accountable for that. Okay, so now you have, let's say, a hospital of 10,000 people. So now you have 10,000 people's perspective on what your culture is really like. So what are you doing to change it? Are you bringing more conversations? Again, are you sharing, which we know they're not? Share the surveys, share what other people are saying, because you're only as good as the people within your system. If your people are not happy, if your people are on LinkedIn, on Indeed, whatever, looking for their way out, it's already broken. The change that you say you want to see is not there. The fix for your culture that you want to see by sending out those surveys is not there. So that's where you need to bring people in. You need to share those surveys. You need to share it with your team. Even if say it's just a survey for your entire unit, you may have 100, 200 people within your unit, within your department. Look at those surveys. Share those surveys. Share the comments. 9 times out of 10, they're anonymous anyway. And when you read one, you'll know if it was you that said it or not. But again, I think it opens up that communication. It opens up that uncomfortable conversation. But that's the only way we're going to fix things. We're going to change things by putting them out there, by having that conversation. I mean, if I'm off base, girlies, you tell me, because I'll shut the hell up right now. But I just feel that that's probably one of the biggest things, is we're not sharing that information. We're not sharing those stories with everybody, to where someone may have put something in a survey that they've been holding on for years, and they've just been shut down, and they've just not said it out loud. Well, now they've said it in a survey. Say it's a nurse of 30 years, and she has all of this experience, and she's about to walk out the door. Were you aware of that? Did you know that? Did you know that she was going through what she's going through, or she's been witness to something for so long, but every time she brings it up, nothing happens, nothing changes? 3 months, 6 months down the road, nothing's changed, nothing's happened. It's never been brought back to her. Thank you for saying this. We're going to work on this. Let's circle back to this and talk about it again. Give me a few weeks to kind of look it over. Let's have a conversation. Let's bring it to other people. Let's bring it to higher leadership. That's the way you're going to fix your culture, is by bringing everybody in and having those conversations. I mean, that's how I feel. That's how.
No, I completely agree. I think, and if your culture is to a point where it's so not bad, but disconnected, I think you start with an anonymous survey, and then you take that, you take that information, and then you do something with it, and then you show your team, okay, we've received the results. This is what we're going to do. These were the answers. This was the majority, and here's what we're going to do about it. And then you do it. And then what happens is people see they're listening to me. They're listening to us. That opens people up. It opens people up to them maybe come forward and start speaking again, start speaking their ideas. We're nurses, frontline workers are at the bedside with the patients. We're using the tools. We're using, the equipment. So we sometimes have to do workarounds. We have all, I can't tell you how many conversations I have with my, colleagues who are like, oh, this would be a great, invention, or this would be great if we had this, or, this to help this. So many wonderful, innovative ideas. And it's just gold sitting there, I feel like. So, if we are able to open up your team and open, or wherever you may be, to then come forward and share those things. I mean, I think it would really change healthcare in a whole. But I think it goes back to, do they really want to hear that information, is the bottom line.
And I would like to add a layer of this. As international educated nurse, unfortunately, and this is very common, I can tell you, it's happened everywhere. International educated nurses, especially in the first 2-3 years of their work abroad, they kind of lie during the survey. Not because they want to lie, but because they're scared, especially if they are waiting for the visa. Okay, in USA you have the green card that happened quite quickly. In UK we have 5 years of visa sponsorship, and actually they're thinking about extend to 10 years. So imagine how this change in the law of visa sponsorship can impact nurses, even to answer simple survey. Because I mean, we voted with the Royal College of Nursing a couple of years ago, 3 years ago last year, to know if nurses wanted to refuse the pays increase that the government offered to them. And so many international educated nurses didn't vote because they were afraid that somehow the hospital, the organization could know about their vote, so they could fire them. So, destroy the sponsorship. So I would like to add another layer of this conversation, because, international educated nurses now represent a good number, different number across countries. But in UK, for example, nearly 30% of the registered nurses. So imagine how much 30% of nurses can actually influence the vote. So we don't really have a real data. So what I always say that when you do a survey, please make sure to create that psychological safety, even if it's anonymous, right? Create that, because it's a matter of culture. They come from another country. I come from another country where survey are not really real. They're just made up. So you make people trust that they can share their thoughts. So I would like to ask, because you talk about survey, you know the data, and also you saw all these changing. It's all this, system deficiency. So did you see this thing? Did you see maybe survey have been answered, not complete truth? What is your feeling? What is your sense about? Also thinking about international educated nurses.
Yeah, that's when you feel like your whole life might be dependent upon, your answer with a survey. That's huge. I can imagine people would be scared to truthfully, say how they feel or what they think. That adds a whole nother layer to it. More to the point of why anonymity, I think, in that case is so important. If they really want to extract the data and know what it is, truly. But when it's, in my case, when we had our anonymous survey, it was a pretty good reflection of the culture, I would say. But for whatever reason, and again, I will never assume anything. That's what I always say, never assume anything. But we had the information in front of us and spoke about it. It was supposed to be worked upon. There was a couple ideas thrown out about how we would do that, but at the end of the day, nothing happened. I'm not sure if it just didn't make it where it needed to go. I'm not sure if there were other stakeholders involved that I can't say again. I don't ever want to assume, but it really did shed a light on what was going on in our unit, and it needed addressing, but it just never got addressed. So I think that's where you have to kind of pause and say, okay, what are we going to do about it? And then come back to the staff and come back to the team and say, this is a survey and this is what we're going to do about it. And then do it. That's the only way. It's the only way to build trust, transparency, reduce gatekeeping of information to your teams, or else you're just going to have what we see now, which is nurses just working. I think there's something about maybe 30% going to retire or quit in the next 5 years, I believe it is. I think we're at 33% of nurses or so within the first year or two of nursing, like just coming out, that they're leaving. Those are big numbers. Those are scary numbers, quite frankly, moving forward, I think. And I think it paints a good picture as to that we should do something about it. So that's my input on surveys. Anonymity, so important.
Beautifully said. And Dina, my brain was on freaking crack when you were talking. And I'm thinking, all these people that are international and afraid to actually put the truth in a survey because they are so afraid. And we talk about fear all the time. We are so driven by fear in so many ways. So I feel if we don't stop the fear, if we don't create that psychological safety, if we don't create those environments where people feel that they can speak up. And it's not always about bad things, you guys. We're not always bitching and complaining about bad things. That's not what we're here doing. We're talking about things, the good things, the bad things, the great things, the ideas, the innovative ideas, the fixes that we all can bring to the table. But if nobody's listening and those ideas are just being shut down without even opening a door and never talked about again, people stop talking. People stop feeling safe. People start looking for another job. And it is a shame. You know, they say, what is it? Like you said, 33%, but I think it's even greater than that. Actually, in the first 1 to 3 years of being in this profession, that people are leaving, that people are stepping away from the bedside. And it's so much, it is really just so simple to bring people's voices together, to bring those surveys anonymously, however it is, because I'm always curious, what happens with that data? Where does that information go? And is it tracked? And do people feel like it's not really anonymous? I'm being tracked some way, somehow. You know, if you get the email, it comes to your email and you respond to it and you send it back. That's not anonymous, right? That is not anonymous. They know who you are. They know who to target. And that's a shame as well, because we're not really saying, hey, it's safe to speak up here. It's safe.
Right.
And there's so many ideas that people have that are working within the systems. They have so many solutions because they're working it every day. And like you said, we have workarounds. We've got a million workarounds for something. Always have, always will. Because there's always something that's broke or something that's not working or something that could be better. That we're like, hey, I got an idea. And what do? We figure it out. Nurses always we always figure it out.
Yep.
Dina, Ann Wax has said,
I wanted to bring her comment because they were really.
Hi, Ann. Good morning, Ann. Love Ann. Thank you for being here.
Ann is from Canada, right? Or from USA? I can't remember. Anna, if you don't mind, just remind me. Sorry.
I want to say Canada, but she said nurses always feel that someone watching them when it comes to vote in any situation. So no one believes that survey is anonymous. Absolutely. Then she says, surveys are done for the masses, but management does not address the issues. Then people end up leaving. I am writing I'm writing guides for nurses in a proactive way, and I am publishing them now on Gumroad. I'm not sure what that is. Interesting.
It's a website, yeah.
Okay. People feel that they are tracking them. People don't trust safe. Hi. No. USA. She's in the USA. Okay. I couldn't remember either. But yeah, that's what I just said. I mean, we feel like it's not really anonymous. We're being tracked. So then are we later on targeted? Are we later on, is it affected in our in a performance plan? Is it affected in whether or not we get a 1% or we get a 1.5% raise in the next quarter? There's so many things that factor into that fear level and how things are. Yeah. Speak up. We want you to talk about it. If you see something, say something. But yet, slap your hand when you do.
Yeah, but it all boils down to trust. Trust is the key. You know, if you, and then when you have the trust, trust increases when feedback. Have your trust increases when feedback leads to visible action. So if we can't at least get nurses to truly trust these surveys, you're not going to get the information, the real information you need. And it doesn't have to be huge. It can just be, there's so many different surveys out there that you can make anonymous. It doesn't have to be tied to any sort of, your work and email. It doesn't have to be tied to anything within the system. You can just send out a Survey Monkey and just say, here, and do it. And just, feel free to share whatever you want. You'll get the data. You won't get any names. And that's what we did. I mean, I've done many of those. And it's, you get quality information. You get real, just comments, like these. I'm afraid to speak up, afraid to say something. I think that there's, clicks or whatever the case may be. You get real information. So I think once you can do that and get past that and then extract the real information, the real data, then you can move forward. But the next key part of that is follow up. And once you do that, now we're working with something. Now we can start, building off of that. Now you have a culture that's starting to slowly come together and isn't afraid to speak up. And then you do something, you one step more, and you say, okay, how can we extract quality data from what you're actually doing, what nurses are actually doing, the cognitive load, your mental load, those little moments that aren't on the data dashboard, what the shift is really like, not according to the grid, right? And we can actually track for those things and then make it data and make it visible to everyone. And then we can say, oh, wow, well, okay, this is something we need to address. And then how are we going to address it? So those are the kind of steps I see in my mind. I would love to see happen. It's just, how do we get there?
And as being a research nurse, I've loved data because data pick up the truth. You cannot deny data. You can exploit research. So you can exploit data if you want, just make the survey in a certain way so it can give you a certain answer. But of course, if you have a good intent and create a survey that be very inclusive, and also you do supportive talk to bring people to the survey in a way that they feel safe to do it. So if you prepare for the survey in a way that you create that psychological safety that allow all the people to feel safe, then and create a survey that is really useful, not that going to exploit certain results, then yes, you can create a data that is valuable. But then, of course, as you said, you have to act upon the data. Otherwise, it doesn't make any sense. You just tick a box, I believe.
Right.
Should we read some comments, Kimberly? Because Anne says something so true.
She says, I have always been outspoken and I've been targeted. Yeah, me too. I don't have much of a filter.
Same here.
I'm sorry. If something's not right, I'm going to talk about it. And it's not being, raising a red flag or, saying something that will embarrass somebody, not something like that, but just speaking up about something. If I know something is not right, I'm going to talk about it. I'm going to go behind closed doors, bring it up, and we'll have discussion, because that's the right way to do it. You don't want to make anyone feel shamed. You don't want to make anyone feel that if it wasn't like it's a he said, she said kind of thing. You have to have those conversations and get to the truth of it, and trust. Your people have to have trust in you, for sure. She said, I had trust in management, then I spoke up. They did not believe me. And that's also one of the biggest things that breaks my heart, because honestly, to get the courage up to speak about something and to finally bring it to management and then have them not believe you, that's the biggest kick, I think, ever. And then we lose faith in our leadership. We lose faith in the person that's supposed to be leading us through everything. And I'm sorry that happened to you, Anne. I really, really am. I'm going to grab the next one, Dan. New York City nurses settled the strike. I spoke to the nurse that was part of the strike. I asked if anything changed. She said no. Of course not. Of course not. And they stood out in that cold weather for how long? I can't remember how long it was, like 20 days or something, even more.
Yeah.
Safe will not work. It has been ingrained in people for so many years that they are not safe because they see by examples. Right. We see what happened to the person before us that said something, and then we don't say anything. We don't talk about it. We pretend it's not happening. System design. Thank you, our Ben, for being here. System design failure is the problem. If the system is fixed, retention and staffing gap will fixed easily. But can the system be fixed? I think the reality of every nurse is peculiar to their countries, region, and government. Of course, it's all going to be based on proximity. And that's where leadership needs to be, in proximity to their staff. And, like we were talking earlier, Brittany, about the director of nursing example I put in my post today. If you're so pulled to meetings and pulled to this meeting and so disconnected from your team, you no longer have that proximity. You no longer have that vision of where you really can see everything that's happening. That's why I think, again, building psychological safety and building the safety that people can be present and they feel that their presence matters. Because that isn't the the biggest thing is people just want to feel like they're seen. They want to feel like they're heard. They want to feel like, hey, I'm putting my family aside to come to work every day. I'm devoting 12, 14 hours a day to this institution. I should at least feel, I should be made to feel like I matter. My voice matters. And I'm not just complaining, or I'm not just speaking up because for the hell of it. I'm speaking up because this is what's happening. And if you're not,
Right.
if you're not privy to it, if you're not down in the trenches with us and you're not seeing it on a day-to-day, and we're living it on a day-to-day, we're trying to tell you, please pay attention.
Mhm.
We're trying to share this with you. We're trying to tell you what's happening. We're trying to find a solution to what's broken, because it's global. Like Dean said, it's global. And every conversation that I have with people across Africa, Kuwait with Patricia Temple, and Mark in Australia, and Share Gratitude and their amazing program that they have, it's everywhere. It is not just here in the US. It is not just there. It is not just there. It's like you put the whole earth in a bubble. It's everybody. So
It's
how do we fix it?
Yeah, I totally agree with it. I think it was Ben's comment. It is it's a system design failure. And like the question at the very end, and it varies from country to country, but are they willing to see it that way and take advantage of the immense, information and data that nurses give and provide? So I just have a few things kind of here. So 1 in 4 nurses are considering leaving. Higher in nurses who are under 30, it's 1 in 3. The drivers are workload, lack of support, and feeling unheard, and they leave environments, not the profession. And then I think a lot of it is the cognitive and the invisible load, and that's what I kind of like to speak to. And it's the constant like task switching and interruptions, the clinical decision making under pressure, family education, emotional labor, physical labor, anticipation of deterioration. So you're constantly anticipating and waiting for a patient. You're watching a patient closely. You just have that gut feeling. That gut feeling is gold. Or waiting. There's so many things we're kind of anticipating in nursing. You're always prioritizing things. We coordinate across teams and systems. As a charge nurse, I feel like when I think of charge nurse, my mind just kind of shuts down, because I'm in that role. And at the end of my shift of whenever I work charge, I would just feel so consumed and I feel like I was just a puddle at the end of the day, because you want to take care of your team. You have to look after the patients. You're managing family dynamics. You're managing your facilities. You're managing the system dynamics. So many different things. You are coordinating with other units. So I think, and then documentation burden, and then actual care complexity. So again, that's like that acuity level versus the grid. Making sure you have enough nurses, making sure you're being pulled from another unit. That's an anxiety for some people. There's so many things that that are considered, right? Especially if you're chargers, you're making the assignment. If this nurse is relatively new, or this nurse is being pulled from another unit, they can only do certain things according to this policy. There's just so many things, and what we don't measure are those things and the near misses, right? They don't measure the things that we catch. And that is, I think, part of the issue too.
Yes, and exactly. And I think this go back to the fact that, Avari said that this is a system failure, and there are nuance, peculiar to country, region, government. But the thing that, I studied international nursing for nearly 10 years now, no, more than 10 years now. But with Kimberly in this podcast, we continue to talk about, yes, the system is failing, but also nurses are failing with themselves. So culture and policies are different country by country, yes, but the problem still very general that nurses, they're not really support each other. So I think that we should keep an eye on the system, but again, if we don't reconnect each other and together we find a way to restructure the system or give our idea, because as you say, there are near missing or things that only nurses know, right? So if you are not united and speak up, our ideas, our data, the data that really impact on retention and patient outcome, we never will be able to say to the system, listen, system, this is what is really wrong. But the system knows only what the system knows. The system doesn't know what is a life at the workplace of a nurse. And this is why I believe all the system around the world, they now think they can solve the problem with AI and innovation because they know what is the workflow. But they see only the tip of the iceberg of the workflow. They don't know what the workflow of a nurse is really about. Only nurses know. So the problem for me is we never be able to, put down Goliath if we are not strengthening our commitment and belief. If we don't believe in ourselves that we're able to fight Goliath, we'll never be able to do it. The first step should be in us. Within us, probably, for sure, all of us, because also this being stretched, abused, constant fears, constant calculations, constant emotional drain. We cannot really reconnect to the nurses as well if we don't really work. It's hard. This is a very big what I see is very big commitment that we must ask ourselves. But the point is we are on a cliff now. If we don't do it, who gonna do it? Because I also pick up some data and I can see that. So the data say this is global from the Royal College of Nurses. So maybe USA have slightly different data, UK different data, Europe and so on. But internationally, cumulated data, Royal College of Nurses say that the first year nurse of being registered nurse, 80% leave, and these rise up to 34% up to the third year. Not just that, we will have so many nurses retired. So we're going to have still Royal College of Nursing. So that will be roughly around 17% in the next 5 years we're retired. And considering the baby boomer nurses that started retiring a few years ago, but will continue in the next decade, we have 22%. So around 660,000 baby boomer nurses will retire worldwide. We're going to have a massive loss of nurses. And so not just workforce itself, but knowledge, experience. So how can we actually rebuild this profession that is just breaking down in pieces? We can continue to say that this is system failure, and I agree, because I think the thesis doesn't be built against us, but still it's not a good system for us. So we should do whatever we can about. But if we don't really rebuild the profession, if we don't really support each other, how can we bring this conversation to the system? This is my fear. This is my point, to be honest.
No, I think you're absolutely right. I'm sorry, Brittany, I didn't mean to cut you off.
No, you're good.
I think you are absolutely right. And, we, like Mark Carter always says, you need to take the emotion out of it. We have to take the emotion out of it to really have it impact the system to where they understand, for the stakeholders, the shareholders, the CEOs, they understand it has to come down to ROI and KPIs and all of that. That's how they're measuring it. They're not measuring it by what we're dealing with on a daily basis. They're not measuring it by what we're seeing and how we are impacted. When you were talking, Dina, I was trying to think of, a day when you're just coming on the unit and you've just got report and you're headed down the hallway to see your first patient. Well, a family member stops you. Hey, are you in so-and-so's nurse? She needs da-da-da. So you get pulled in that direction. And so that's put you 10, 15 minutes behind. And then you're headed down the hall again to see your first patient, and a call light goes off. So being the nurse that you are, you answer the call light. That takes more time. And then when you finally get to your patient, they may have 100 questions. They may have so many things. There's so many things that happen in that first half hour of your shift that put you so far behind. And when we're stretched so thin, there is no one else to kind of pick up that slack. So then all day long, I always feel like I'm just chasing myself because I'm behind all day. And now it's, say, 5 hours later and I haven't went to the bathroom. I haven't gotten a chance to eat anything. I'm dehydrated, but yeah, I'm trying to push through it because that's what we're constantly doing. We're pushing through it. But those are the types of things that the metrics aren't showing. That's the types of things the data is not showing because they're not boots on the ground. They're not walking a day with us ever. And the more tasks that we're given, the more documentation, the more check boxes that we're given, that's more time away from the patients. That's more time away from us being able to even care for ourselves, to be able to, again, give good care to the patients. Because we are pulled in so many different directions. And I don't care how much data you have, how many metrics you have. You seriously cannot measure a day in the life of a nurse. You just can't. There's so much that we do that never gets documented, that never shows up in the data, that never shows up even as a question in a survey.
So much.
I feel that that's where so much has to change as well. Walk and do a day in the life of a doctor, a day in the life of ultrasound tech, radiographer,
RT, yeah,
anybody,
CNA,
housekeeper, janitor, the boiler guy. Yeah. I mean, those are all the people. It's not just nursing. Right. It's bringing all of those perceptions, all of those perspectives together in those surveys that you're asking. If you really want to know, ask everybody.
Mm-hmm.
Ask everybody.
I was just thinking about what you were saying, and I'm always trying to think of like just different innovations and things. I've just had that kind of brain like pattern, putting things together. And I was just thinking, how can we actually measure exactly what you just said, right? You're going down for your shift, and you're going to see your patient. You're going to see this one patient, but you've just been pulled 6 different ways before you even got there, right? So, as you start your shift, you already have like you're prioritizing, but there's so many different things that come in between. Like, what if we had a type of button, not linked to anybody? It wasn't not linked to any specific nurse. So it's not a trackable thing. And that's another thing, is you have to have trust in your institution, so your nurses trust the technology, because it could be something so simple, but every time that you're stopped or interrupted, you just tap. And depending upon the level of, interruption, it will get like 2 taps, right? If it's a family emergency or, a code or whatever it may have you, depending upon that. And then you take that data and then you say, okay, what happened on this shift? You kind of link it back and just kind of take those. That might be a way to really kind of see, you just kind of tap your badge. I don't know how often, for me, when I'm talking to families, I'm usually hold of my badge, or, I'm already up there, but I was just thinking, if we just like tap, and like no one would notice, but it would send a message to a dashboard, or send a message to, eventually, if it were to, grow, to the charge nurse, or to or somebody, just to say, this unit is having a lot of clicks today. They're having a lot of overload, or cognitive overload, burden, whatever you may call it. But anyways, that was just an idea I was thinking of.
I think that's brilliant. I think that's brilliant. I mean, that is just so simple. Just a wait, tap, tap. Okay.
Yeah.
Like it's almost like I'd say sometimes, all right, I'm tapping out.
Yeah, exactly.
I'm done. I'm tapping out today. I am fail. No, I think that's a great idea. And if we talk so much about AI and we talk about innovation, and people are so afraid that it's going to take the nursing jobs away, it's not going to take our jobs away, because AI can never be the touch.
Mm-mm.
AI can never be that calming voice that sits with you at the bedside and walks you through some of the toughest moments, or for me, some of the greatest moments of, it's that final push. I got you. AI is never going to replace that,
No,
but
there's
I think-
something special about that. Definitely.
Yeah. So it's never going to take the human out of humankind. It's never going to take the human out of our profession. But I think that's a brilliant idea. And see, it's just these conversations like this, you guys, we're just, bouncing things off one another. We're brainstorming. We're talking about this. People in the comments are bringing things to light. And Dina, do you want to go back through the comments, and I'll grab Anne's comments?
Yeah, I
again?
just wanted to say something, because now that you're talking about, I connected that, because working on retention, one of the things that I wanted to catch is something like that you say, Brittany, but I never thinking about the button. But now you say button, and we talk about AI. We actually have wearable that can catch everything. So I think that maybe could be too expensive to analyze all the recording for every day for every person. But if at some point we have the resources, technological resources, at least it could be done. I still think it could be very expensive, but I think the fact of the bottom, or anyway, the fact to be able to record data that can be seen, because it's the lower part of the iceberg.
Mhm.
Maybe this could be a very good point, because we are so busy in doing our things that even if we are distracted, and because we are distracted all the time, we cannot recall at the end of the shift and say, yeah, today I've been distracted 23 times. I was doing this. We cannot recall, because we are so focused on what we're doing. So I think the fact that bottom of, AI, wearable, whatever, could be a good point. Maybe someone listen has the money to do it. Let's say we gave you an idea, guys.
Yeah. Well, even today, like with Epic and some EHRs, they actually can track like task switching, clicks, time in the chart, items like Voceras that people use. They could track interruptions, the message loads. And then if we want to go a bit further, I think there's this one technology called NASA TLX. It's a validated cognitive load measurement tool. But either way, it's just kind of, we're already using some of these things. So if an institution or a system just want to take a look and see what do we currently have, and AI is infiltrating almost everything. So how can we use what we already have? It may not be expensive at all. Again, it's going to just come down to, do we want to measure it?
So some comments, where we were with the comment.
Go to Jordan. What did Jordan say? Jordan Lott.
Oh, yes, there we go. Yes, thank you.
So Jordan Lott says, I agree. Where healthcare currently stand, it requires redesign. It is not that we don't have enough people. The issue is efficient use of staffing. This avoids many issues down the line that would actually prevent a harmful incident to occur to the patient. This tends to happen due to unsafe staffing assignments. It is a systemic failure. It is. And we talk about that all the time, the patient to nurse ratio. And, Mark was actually working someplace where it was 1 to 70. It was him and 70 patients. How was that even? When we had the conversation, it's like, I can't even wrap my head around that. I've had 1 to 30, I think 37 patients when I did long-term care. And you were lucky if you had 2 CNAs. There was many days I had 1. But we talk about all these distractions and all these things that pull you away from giving the care. The call lights. There's not anybody to answer the call lights. The falls, the med passes, the AccuChecks, the wound care, the the family members, the meetings. I mean, there's just, if you could just have one person that just handled that part of, all the distraction part, you might be able to get through a shift safely. But, when he said 1 to 70, and I'm thinking, that is not even feasible. That is not, how is that even safe? How is it even safe?
How is it even safe?
And I see these conversations all the time, and I talk to CNAs all the time. And I started out as a CNA, and I remember having the whole floor. And at that time, I'm not even gonna say how old I am, but back in that time, if the next person didn't show up on shift, you were automatically mandated to stay over and work the next shift. And that happened almost every single day I worked. That's 16 hours. As a 17-year-old CNA, that was my life. But I learned so much respect for patient care and wanting to go above and beyond, because it was only me. And you build a rapport with the patients, especially if you're with them all the time. You build a rapport. They know that you're short and it's only you, and they oblige. But they shouldn't have to. They shouldn't have to, bow down to less than stellar care because there's nobody that's there to take care of them, which is so sad as well. I could go on and on about that, but yes, the unsafe patient ratios is something that I think we have a conversation about all the time. And where that gets fixed, God, that's a whole nother broken system in all itself.
And one that I think that hospitals would want to address, because it would save money. Hospital incidents they cost a lot. So I think, I've never been up in that type of role working with that, but I would imagine you would want to invest in how to prevent, medical errors. We document them, we identify them, but again, where are we kind of measuring the near misses? Where are we catching, what's being done before the event? And then how do we do that better? How do we improve upon that?
Absolutely, because the acuity doesn't change. It only seems to get worse. The acuity of patients, the number of patients, the number of more and more staff that are leaving because they just can't do it anymore. It's not sustainable. I can't do this every single day. I can't work 16 hours every single day. How much time does that leave me for my work-life balance? There is none. Go ahead, Dina. Go ahead.
Han has a very good point, because she said the patients are sicker and more overweight than they used to be before. And the younger nurses are feeling the back problem at the early age. So this is an amazing point. And thank you very much for your contribution. Because 30, 40 years ago, nurses had a kind of work, right? And they deal with a certain kind of patients, right? For sure, we overcome many things with medicine, science, but the thing is now patients get thicker and thicker, overweight all the time because of the lifestyle, because of toxicity of the food, environmental problem, pollution. So this is a very good point. We know enough to care for sick people, plus the people are sicker and overweight. So should we read the other comment? Kimberly, do you like?
Yeah, let's do Ben's comment.
Oh, do you want to say something about this? Sorry.
No, I think you're absolutely right. Absolutely right. No. So Anne said, what's happening there are concierge nurses. People are taking their own life in their own hands. We are seeing more concierge places open up here, where it's a doctor and it's a NP, or it's a RN, or it's a LPN that's working in clinics, because people feel that they get better care with concierge rather than then they have 24/7. They have someone on speed dial that they can ask questions, they can talk to. They feel that the care is better, but it is very expensive. And that's another thing where healthcare is so expensive that it's out of reach. I haven't had healthcare insurance for quite some time. And for me, and having long COVID, that's not the greatest idea. But again, it's not sustainable for me. So it's those things that we pick and choose. Do I pay my rent or do I have health insurance? And I think so many people are doing that kind of math as well. We're always, like Mark and I always talk, we're always rationalizing what we do, what we have, what we can afford, and how that affects care and the acuity of patients. Are they sicker because they've put off care for so long? Do they now have cancer because they didn't seek treatment, or they knew something was off but they couldn't afford to go, so they didn't? All of that math just kind of goes around in our heads, and I can speak from that. It goes around in my head. It's like, I really need an MRI, but I really can't afford $3,000 to go get it done. So I'll put it off for another year. Again, it's those negotiations, and again, that's where the health system has to get better. Health insurance has to stop trying to become so rich that nobody can attain you anyway. Nobody can seek care. No one can afford your health insurance premium. So where are you winning? And then people are dying. People are getting sicker and sicker. And then when they do come to us, it's almost unmanageable. Their situation, their health is almost unmanageable. And then there's no return from that. And where we could have fixed you 5 years ago, we could have helped you. Now, I'm sorry to tell you, there's nothing we can do. And that is so sad. And that is so sad.
And people are living longer. They're living longer. And speaking, I think it was to Anne, they're sicker. They have more comorbidities, more, at least here in America, that good diets. They're more overweight. They're harder to care for. And then again, when you have low or poor staff ratios, it wears you physically, mentally, emotionally. There's
so many ways.
And so also so many chronic conditions, but also I think people have become more demanding of what the care should be for them, which is right. I not say they should not advocate. Actually, I keep to my patients say you have to learn how. Unfortunately, you have to learn how to advocate for yourself, because how the healthcare is stretched. So it's right that became more aware of their health need, that became more advocate for themselves. But of course, if we see from the other side, it's become another overload for us. So so many layers, this healthcare system problem.
So many layers. And I will say, like, work in transitional care, it's you really see all the different layers and aspects that affect an individual and their healthcare needs.
So Anne says nurses should stop apologizing for how they care for their patients. We should stop apologizing for a lot of things. We're always apologizing for, I'm so sorry, I didn't get to that. I didn't have time. Oh, I'm so sorry, I'm so sorry. I didn't forget you. I got busy. You know what I mean? We're always, I think we must say I'm sorry how many times a day. Unfortunately.
That's the truth.
What does Ben say, Dina? He says,
Abari, you mean?
Yeah, Abari. He goes by Ben. Ben says, so nurse Dina Paoloni, love her. You spoke very well. However, I'd like to clarify my earlier point. The challenges facing nursing vary significantly across regions, countries, and governments. Even issues that appear global are not experienced or even recognized in the same way everywhere. A clear example is the migration of nurses from developing countries to developed ones. This is largely driven by deeply flawed healthcare systems in their home countries, which push professionals to seek better. I'll let you answer that, Dina. I'll let you answer that.
I agree. This is my work, so I absolutely agree with you. And I study international nursing for more than 10 years, immigration nurses. I'm career coach specifically for international educated nurses. And actually, the RCN and try to raise this point to all the developed country to say, don't pull so many nurses away for their country because you prefer pull them from abroad, recruit them from abroad that actually retain in your country or form them in your country. And actually, the International Council of Nurses did I say RCN? No, it's International College of Nursing. And they actually work with the UK government, and they together released just last week or 2 weeks ago, they released a file that said the UK in the past year was able to save 14 billion pounds, now you say, so even more, by recruiting nurses from abroad. So you understand how, because it's a cheap labor, right? And nurses leave their own country. Sorry, Brittany, what's covering your face? So nurses, they leave their own country. They leave especially for two big reasons. There are also love, stories, etc. But it's money and a safer or more valuable working system, okay? I come from Italy. The salary is nearly 1/3 of the salary in UK. There is a flat nursing career, so there's no career actually. There's nurses, and there is the manager, and there is the nursing director. That's it. There's not really much in between, at least this for every country. And if a nurse is specialized, so they go for master's degree, PhD, they are available in Italy, right? But does anything change in their workplace? So they still work at the same level. They don't have any salary increase. They don't have any independency as well in their job. So this is why many Italian nurses are leaving for UK, for Canada, for America, Australia, New Zealand, and so on. And Italy, in fact, is just telling you, Italy is some professors in my country, but there are so many, especially from Africa. Italy is lacking of around 65,000 nurses. And do you know what Italy does to have more nurses? They recruit from Albania, from Africa, from other countries. They are poorer than Italy, so that they can have cheaper and more compliant nursing workforce. They can manage better. So they save by recruiting from abroad. UK does the same. USA does the same. Every, wealth country is able to do it. He's happy to do it. And so I'm Ben, I'm so totally agree with you. And unfortunately, it's something that I try to, of course I cannot do by myself. But if I keep educating nurses in this matter, I can empower nurses. And especially now that for all this change in healthcare, AI, climate change, retention, etc., generational shift. Now nursing is, I can see because I studied more than 10 years, nursing need more and more of guidance. So career coaching is so needed now more than before. And this is why I try to involve all the people in becoming career coaching. But the problem here is that, of course, you cannot stop a nurse, because if any person is not, who doesn't like their life in a country because of war, politics, salary, corruption, whatever, this person wants to leave the country to seek a better future abroad. You cannot deny. Okay, there's no perfect place. There's no an El Dorado, right? But it's the right place for you. So why cannot you really have this life for yourself abroad? So I understand that ICN want to keep nurses in their country, because if they leave, that the country become even more depleted by nurses, and that the healthcare system get worse, right? And this is why they try to stop international recruitment. But is this fair for nurses themselves? They are kept in a kind of healthcare system that exploited them, don't recognize them. It's complex as well. So Barry, I really agree with you, and I think I talk too much about this, but this is really my thing, and I'm so passionate about it. So I didn't want to dismiss what you said, Absolutely. It's just wanted to say that internationally educated nurses, when they move abroad, they become like more vulnerable comparing to native nurses, for several reasons. But anyway, sorry, I digress. I really digress. Apologize.
No. You were the perfect person to answer that question from him. I'm not. That's not my wheelhouse, and that's not Brittany's. That's you.
Mhm.
And I think that anybody watching, anybody listening, who is considering moving abroad or trying something different in another country, they should reach out to you, because you are the expert on this, and you've done the research. You've done that. Shut up. You've done. Shake your head.
I don't authorize me in this podcast.
No, you are the.
She always does. But yeah, that's okay.
You are the expert. You are the expert on this. And if people have questions, they have ideas, thoughts, they want learning how to navigate, you are the best person and the best resource for them. So I highly recommend anybody that's watching, anybody that's listening, if you are questioning, do I stay, do I go, do I move abroad, how do I do it, what are the steps, and what do I need to do? You are the person that they need to reach out to. So high five, love you long time. Yes.
Me too. But no, the point that I would like to bring here is that it's important to involve international educated nurses in the conversation, make them feel safe in joining the conversation, because different percentage, but they represent a good portion of the registered nurse. In UK, we are nearly 30%. So again, when we have to do a survey or vote for certain things or making a decision to change the policy, you have to involve them. It's not a matter minority of equity inclusion, which is, by the way, but I'm not talking about that. I'm talking about being more smart in understanding that we should involve everyone, especially those who feel more vulnerable and scared, because they represent a good portion. So my point is you don't need to involve internationally educated nurses necessarily for equity inclusion, which is very right, and I am a minority as well in this country, but you have to do it because you have to be smart as a nurse, as a nursing profession. Yeah, you don't give. It's not an act of kindness or be better together inclusion, which I believe too. Okay, it's more as well is get smart, guys. So we have to, you cannot talk about this as a politics issue, left or right or whatever. Okay, it's just you need to involve everyone, but you have to make sure that everyone feels safe. Because I said before, international educated nurses are tied to their visa. Not just that, they are tied also to their contract, because when the recruiting agency bring them from where they are and bring in the country, they ask them to sign at least 3-year contract. So they have to stay there at the bedside. They cannot even do career. So they lock there and they cannot escape. Otherwise, they have to pay massive penalty. So this is so what I really try in the past years, since I became career coach, I started advocate for international educated nurse, is involve international educated nurses in the conversation, not to please them, but because it's a smart decision for all the nursing profession. Understand what I mean? I hope that I express myself properly.
Yeah, I learned a whole lot right there.
You are amazing. I love
Truly.
you. You are amazing.
Yeah.
No, I think you have so much insight. You have so much knowledge, and you've done it. You've been there, and you do help other nurses. And whether you're international nurse, whether you're a brand new nurse, whether you're just about to graduate nursing school, and you're a nurse, you're in this profession because you love the profession and you want to take care of people. So we just all need to start taking care of one another, no matter where you are, no matter your culture, no matter your background, no matter your diversity, any of that. Just be a human being. Just, we're all nurses, and we're all here in this for the same reason. And that's where we need to get around. That's where we need to support one another and provide just kindness. And I know Ashley Scott always tells me I'm all about butterflies, unicorns, and rainbows, but I am to a certain extent. But I think it's just so simple, those little bitty things. But yes, so anybody that's considering doing abroad, definitely reach out to you,
Stop
Dina.
it. It's
You
okay.
definitely must have it.
They've got the link in the comment box and the descriptions. They can join the community, which is free. So Nursing Move Career Coaching Community is free to join. There's so many things, resources. So okay, I've done my advertising.
Stop it.
And
And if
I'm
you
very-
need help in the US, I can help you at Unapologetically You Collective. So coaching and mentoring, helping, not even want to say helping, guiding people to that pivot, that third path. And I was just thinking about the other day, sometimes there's a fourth path. There's that path that's not paved yet, that one that you're just really curious about. So I would say just be curious. Be curious. There's so much out there. There's nothing that says that you're stuck. There's nothing that says this book is closed, that you're done. You have to stay.
Yeah.
But it's finding those other paths, but taking the time to really always come back to your why. Why did you get into this profession in the first place? Think of a lot of times. I think people are so focused on what's broken, they forget what's not, and why we got into this profession into the first place. And I encourage people all the time, journal. Sometimes putting it into words and just writing it down and reading it back to yourself. People have these epiphanies. They're like, wow, I was so focused on what was broken, I hadn't really thought about what's really good about it anymore. I've been in this toxic environment for so long, but now that I wrote it down, now I'm kind of venting to myself. Now I'm kind of having the conversation that I wanted to have with someone else, but couldn't because I was silenced. I'm having this deep conversation with myself, and I'm like, wow, I'm finding solutions. I'm finding that I love where I'm at. I just don't like what's happening where I'm at. So let's fix it. And that's where those conversations come in. Let's fix it. Let's talk about it.
And this is why we do this podcast and this conversation as well. And Brittany, we're very chatty. I don't know if you realize that.
Oh, what? Oh,
yeah, you're very chatty. Sorry about that. But yeah, I mean, I'm very aware of the time, and we're having an amazing conversation. I would like to ask you. I think we are about to close, but we'd like to ask you to share an idea or your thought or an advice or what this conversation left to you today, just because unfortunately it's 1 hour 40 minutes, we nearly 2 hours.
It always happens, Dina.
I know.
It always happens.
Always happens to us, so I mean you have to get prepared though. But yes, I mean I love this conversation. I'm really grateful for you, and I hope that we continue to do our conversation together and post, comment, and so forth. But please share with us. Take your time, by the way. We not have to close at 2 hours. We're happy to continue, but please share your thoughts, your advice. What do you think we should go for it after this conversation? What this conversation left to us? Thank you very much.
I think to kind of echo Kimberly's statement about there's so much out there. So since just when I took a step away from the bedside, I initially felt very lost, but I have gained so much just in the last year and a half. I've learned so much. I've met and had so many wonderful conversations with so many wonderful people, Kimberly, Dina, people on LinkedIn. I mean, and through my work, meeting new people. And you really get to realize that nursing, the skills that we come out with can really translate into so many different areas. And I think that is a very important and strong message to share with nurses, is that you're not stuck. I know sometimes it can feel that way, and especially for people in certain circumstances, but there are great companies out there that want good nurses and people who care about patients, and they want your ideas, so it's scary taking that first step, but you will find so much out about yourself. And just as Kimberly suggested, that was another thing I started doing was journaling. Just as, through grad school too, they always recommend you do, because I'm in leadership, leadership journal. And I did. I started putting together just like little clips and stuff, but it really helped me to, I think, find myself again and find my why, and rediscover what I want to, who I am, and feel good about that, and strong about that, and find my confidence again. And I'm not afraid to speak up, anymore when it needs to be spoken. And I believe in advocating for myself, for my patients, for my coworkers, for my team. And I'm just really grateful for me, a year and a half ago, making that step. So I currently am in a role where I feel supported, and my input is valued. And so for any other nurses out there who are, maybe feeling the way I did a year and a half ago, it's scary, but it's worth it. And never stop thinking, never stop advocating, never stop speaking up. I know even that's scary, because sometimes there are consequences. And if they happen, they happen, but they'll make you stronger. And you will find yourself stronger from it. It'll be really crappy in the moment, but it will make you so much stronger, and you'll rise above it. And that's it, I think.
Thank you so much.
Thank you. This has been wonderful. So fun.
That was beautiful. Thank you, Brittany. Yeah. Thanks. I mean, I think you just gave so many people watching or listening that courage, that little nudge, that little, you got this. How many times we want to hear, you got that. And that sometimes it just hearing it from somebody else who's had that story, someone else who has pivoted or has done something different or has stepped away from a role and has decided to move on to something else. Sometimes just hearing that, me too, somebody else has done it. Okay, she did it. I got this. I can do this. I can do this. It's not as scary as I think it is. It's not as scary as I think it is. And moving forward. So it's been an absolute pleasure having you here today. And I'm so glad that you and I had come across one another in the comments and on the platform. LinkedIn has been such an uplifting, inspirational, just motivator, I think, for so many people, myself included. And, I found Dina here. So it's definitely been queens lifting queens and kings lifting kings. I say this is welcome to the queendom. So, thank you so much for being here and for all of your insights, your wisdom, and telling us your story today. Much appreciated. And I'm sure that Dina would agree that we will have you back in the future for sure. And this is season 3, episode 12. And
I didn't say it.
Go. So next Sunday is Easter. So next Sunday we will be pausing for everyone to enjoy their Easter Sunday. And we will be returning again on, what was it, April 12th? Was it April 12th, Dina? Yeah. April 12th.
Yeah.
So April 12th
the next Sunday, of course.
So April 12th, we will be back with episode 13?
13.
Season 3, episode
Season 3, yeah.
Anyway, we'll be back then.
We're so glad of this podcast. People are so enjoying it, and we are so glad to have all these people follow us and share their thoughts. And thank you very much for coming and to share your thoughts. They're so useful. And Kitty as well. Thank you for this really amazing space for Share the Nurse Journey. Thank you for coming along and share with us. So I actually didn't say at the beginning, we are streaming from YouTube and LinkedIn today. It really depends, StreamYard, how it behaves, my StreamYard platform, but I couldn't go live on Facebook. Anyway, LinkedIn and YouTube. So if you're watching the recording from YouTube, please share and subscribe so you can help this channel grow a little bit more. Please continue to follow all of us. Brittany, Kimberly, myself on LinkedIn. Interact with us in the comment. Thank you very much for joining us. It's always a pleasure meet you this Sunday, and have a lovely evening, morning.
After we end, Brittany, stay on just for a few minutes after we shut the live down, because I want to talk to you for a few minutes before you go.
Okay. All right. Thank you, everybody.
Thanks, everybody. Thank you for spending almost 2 hours with us on a Sunday morning. Now go do something fun. Get out of here.
Enjoy yourself. Bye.
Enjoy yourself.
Go away.
Bye,
Enjoy yourself. Bye-bye. Thank you.